Hi, everyone, and thank you for joining this webinar. My name is Shamira Foster, and I'm with the Aurora African American Health Coalition. The workshop today is part of our Black History Month series and will be led by Dr. Shondra Clay. Dr. Clay will be sharing some information on maternal and children health crisis, recommendations and strategies and tips for healthcare providers. Dr. Shondra Clay is an associate professor of health scientists in the School of Interdisciplinary Health Professions of Northern Illinois University. Prior to this role, she served as a research analyst at the Counseling Center at the University of Illinois at Champaign-Urbana, where she is a three-time alumni, having entered a BS in community health and an MS in public health and a PhD in community health and specialization in biostatistics. As health as As a health disparities researcher, her work centers on identifying and understanding gaps and barriers in health outcomes across diverse populations with a strong focus on maternal and child health in particular. She investigates high rates of adverse pregnancy outcomes among Black and African American women compared to other demographic groups, striving to uncover the underlying causes and purposes and propose strategies to address these inequities. We will have a Q&A at the end of the session, so we ask that if anyone has any questions, you just leave them in the Q&A area, and I will ask Dr. Clay them at the end of the session. I will now turn it over to you, Dr. Clay.
Thank you, Shamira, for that introduction. And thank you all for joining me. I do want to acknowledge the Aurora African American Health Coalition. The organization is doing some fantastic work in the community, and I am extremely excited to be here today. So again, my name is Dr. Shondra Loggins Clay. I'm happy to be here in recognition of Black History Month awareness by the coalition. Today, I will be presenting on maternal and child health crisis, recommendations, strategies, and tips for healthcare providers. So I'll get into my agenda in a little bit. But overall, my goals are to one, I want to increase awareness about what is happening. And I'm sure we're pretty familiar about this crisis that's happening. And then I want to provide some tangible strategies for healthcare providers and healthcare workers in general working with this population. So again, for the agenda, I always like to start out with a little bit of some personal background. I've been doing this research for a very long time. It's personal to me as a Black woman, a mother, and also working with a team of Black researchers, which include medical providers as well. After the personal background, I'll go into the significance of the issue with just the research overview because this helps also shape the strategies and tips for healthcare providers that I will provide. And at the end, I want to definitely leave some time for some questions. I may not be able to get to all of them, but please, I'll also drop my contact information as well. So always feel free to reach out. I'm always happy to converse. So just as a little bit of background, again, thanks Shamira for that introduction. I won't go into too much depth about this. My education, I received the BS in community health, MS in public health, and PhD in community health with emphasis in biostatistics. My research areas of interest, racial and health disparities in maternal and child health, and I also have a second stream of research in rehabilitation studies looking at the utilization of assistive devices. I am currently a department chair, an associate professor, served as a research data analyst, worked for the Illinois Department of Public Health for a little bit as an intern, and also have a few other endeavors. So I like to share this because all of my experiences, it actually shaped my research and also direct the topics that I talk about. So I look at things from a community health, a public health lens, and I also look at things from a data-driven lens as well. And so jumping right into this topic, the maternal health crisis, maternal and child health crisis. This is a big deal. We've seen it in the news. We've seen some high profile athletes also talk about this issue. Serena Williams, and I'll reference this in my presentation as well. But we also had the Tori Bowie and also Felix. So this is a big deal. It's getting and it's definitely at the forefront of public health, and it's been at the forefront of federal initiatives too. So again, why is this topic important? What's the significance? In short, Black women and babies, they're dying. They're dying at proportionally higher rates than other racial ethnic group dynamics. And this kind of explains why this research is important and why this is needed. The unfortunate part is that this is not an unfamiliar topic to Black women. And even though it's been getting this traction through some notable athletes, it's not an unfamiliar topic. It is, and it has been a thing. And so the lingering point is why? Why does this exist? So I don't want to touch on too many statistics, but I do want to give a glimpse, a few charts that help conceptualize this issue a little bit more. And so this is a chart from a recent chart from the National Center for Health Statistics, the National Vital Statistics System. Um, this was actually released a few weeks ago in February, early February. So the chart indicates that maternal mortality rate it is declining since 2021. This chart, when I immediately look at this chart, it shows me that maybe COVID exacerbated a lot of these issues related to maternal mortality. But nevertheless, since 2021, maternal mortality rate, it's been declining. So when we are looking at maternal mortality, initially we may say it's declining. What's the issue? And let me back up a little bit. Maternal mortality is defined as maternal deaths during pregnancy or within 42 days of pregnancy. But when we look at those trends, what stands out is the racial disparity. And so this is also an updated chart um, according to 2022 and 2023 data, Black women had the highest maternal mortality rates across all racial and ethnic groups. So, why am I focusing on maternal and child health? Why focus on Black maternal and child health as well? Well, there's a link to infant mortality and also low birth weight. So, based on some statistics, Black women are 3 to 4 times more likely to experience pregnancy related complications. So, that includes infant mortality and also low birth weight. And those inequities exist. The statistics emphasize the systemic inequities and those racial disparities. And I want to take a moment and I want to emphasize systemic as well, because for a long time we said it's on the woman. What is the woman the woman doing to contribute to these outcomes related to maternal and child health, including infant mortality and low birth weight? But the other narrative is, and this is where I put on my public health, community health hat. The other narrative is, what is it about the environment, about the healthcare system, the resources or the lack thereof that are contributing to these disparities and these trends that we're seeing. And that's been a focus of my own research. Really, I like to highlight that there is a multitude of issues that contribute to these trends that we see in maternal and child health, these disparities. And for this reason, it's really hard and difficult to pinpoint causality. So one more chart. I talked about infant mortality. So I do want to highlight the infant mortality rates by race and ethnicity, according to some 2022 data. And so infant mortality is the death of an infant within the first year of life. And this usually happens immediately after birth. And there are many primary causes of infant mortality that we can point to, such as birth defects, preterm birth, low birth weight. Mentioned that a lot. Maternal pregnancy complications, and so this is getting into anemia, mental health, diabetes, heart conditions, blood pressure, sudden infant death syndrome, and also unintended injuries. But this chart is important because it highlights that infants born to non-Hispanic Black women are over twice as likely to die relative to other racial and ethnic group dynamics. So looking at benchmark white women, 10.9 infant mortality rate for non-Hispanic Blacks compared to 4.5 for non-Hispanic white. So going back to our main topic of this presentation, let's kind of discuss the crisis a little bit more. What are some factors contributing to these outcomes that we're seeing in kind of the maternal and child health field? So again, as I mentioned earlier, it's really hard to show causality because there are a host of different factors. And I'll repeat this often. It's the problem is very much so multifaceted. And so there are different theoretical orientations that have guided this kind of topic, but I like a few that I like to reference. And the reason why I bring up theoretical orientations is because, again, it shapes and connect to some of those strategies that I will recommend later in the presentation. And so the first is the National Institute on Minority Health and Health Disparities Research Framework. This framework shows that, again, explaining health disparities in health outcomes, it's complex. It spans different domains, and so it expands biological domains, behavioral, physical built environment, social-cultural environment, healthcare system, as well as different levels of influence. And so the different levels of influence, they are the individual level, interpersonal, community, societal level. So examples of factors are provided within each cell of the framework. And so, for example, if we look at interpersonal and the healthcare system, we see the patient clinician relationship, medical decision making. And I wanted to highlight that one right here because this is one that I think relate to healthcare providers, and one that I'll touch on later. And this also this makes sense. It is interpersonal between two people and also within the healthcare system context. And so that's why I really like this model. I like that this model acknowledges kind of all of those different levels from a micro individual level to kind of that macro um, societal level that impacts some of these health outcomes that we see. And so I also like to present the guiding theoretical orientations because it does connect to what we can do. So another one that I like is the Kaiser Foundation. And you'll see a lot of similarities as it's highlighting some of those social and economic factors. But what I like most about this model is that it explicitly highlights the influence of racism and discrimination driving a lot of the health outcomes. And it's research that has documented that racism, discrimination, and stress, it contributes to poor maternal and infant health outcomes. And this could be in the form of providers not being or being slow to listen to their patients, which I'll touch on later. People of color receiving a lower quality of care, the healthcare system treating people of color unfairly based on their race. And so this is just a more updated version of a more recent version of the theoretical framework that I just presented, and again highlighting those social and economic inequalities, specifically in this one. So again, pretty much saying the same thing. The visual is a little bit different. I really like the racism and discrimination on the outside, kind of like impacting all of kind of the specific tenets of the social determinants of health. So I like this model because it really shows how the intersection of all of these factors is shaped in individuals' experience, their health, their well-being, and their outcomes. So, sharing a little bit of the literature specific to healthcare providers, I wanted to just make you aware of some literature around this topic. So, the broad perspective presented by Chambers 2022 highlight racism during um, maternal care, inequitable care, structural racism, and one thing that's unique that this article highlights is clinicians reported disproportionately higher rates of Black women and infants receiving urine toxicology screenings compared to white women and their infants. So, again, just highlighting some differences in care. Campbell 2021 really talked about the importance of understanding the historical context, specifically for healthcare providers. There was a mention about how Black people were physiologically distinct and fundamentally inferior. Black bodies were medical super bodies and resistant to pain. And this correlates to Black women over-reporting accounts of clinicians dismissing their complaints of pain and or pain during labor and delivery. A couple of others, Rust, older article, but still relevant, 2004, Blacks and Hispanic patients had significantly lower rates of epidurals compared to white patients. In Rob 2018, um, really highlighted again what I talked about in the beginning. Serena Williams experienced a shortness of breath and pain during her third trimester, and essentially it was kind of dismissed by the doctor, who suggested that the pain medication she was on left her confused. Um, One more research article, some literature over medicalization has disproportionately impacted Black women. C-sections, it's common, but it's associated with risks such as infection, injury, blood clots, can lead to respiratory distress, other pulmonary disorders, and the key is here. The key here is that Black women in a lot of urban hospital settings, they experience higher C-section rates. And so holistically, kind of looking at the literature and the contributing factors, um, it's closely tied to social determinants of health. And social determinants of health is defined as conditions in the environment where people are born, where they learn, work, play, worship, age. All of those things affect health, the quality of life, outcomes, risks. So, related to maternal and child health, this looks like all of these things impact the outcomes of the mother and the baby. Educational attainment levels, income, employment, economic stability, racism in the form of mistrust, discrimination, affordability and accessibility of care, the healthcare system, what we talked about before, the environment, so food access, community safety, neighborhood, and also stress. And so, as it relates to like income and limited access to healthcare, Black women are generally more likely to face barriers around accessibility and quality of prenatal care. Neighborhood conditions, living in underserved community, it impacts health, the accessibility of nutritious food, air quality, safe environments. In terms of the support system and healthcare system, Black women um, feel more isolated or don't have as much support, and there's a perception of being unheard. And so, in all, again, there are a multitude of issues, and a lot of times it is a compounded effect of the issues. And I do have a asterisk by stress because it wasn't explicitly in the models, but all of these factors are related to stress. It is certainly intertwined with a lot of the social determinants of health, and it can look different across different racial and ethnic groups. And so this is kind of a model that I came up with. But really, I wanted to highlight and emphasize that stress, historical and current, it's a contributing factor to those racial and ethnic disparities that we see in maternal and child health outcomes. And so I want to do a deeper dive just into stress and what that looks like. So in terms of stress, we're looking at chronic work stress due to discrimination, daily microaggressions, racism, racial trauma, how that impacts health and pregnancy. The stress from implicit bias, discrimination, racism. Black women are less likely to be listened to be believed, to be treated with quality. There are underrepresentation of Black healthcare providers, lack of culturally competent care, the communication barriers, cultural mistrust. And then we cannot forget the weathering hypothesis, the accelerated aging due to chronic stress. And then also we have the medical conditions, so the prevalence of a lot of pre-existing conditions in Black women are disproportionately impacted for a lot of those medical conditions associated with high risk adverse pregnancy outcomes. So the more positive news is that there are some things being done. Um, we cannot lose that energy and that synergy around the efforts. And so now I want to jump into kind of those recommendations. So I want to start at looking at it from more of a macro level in terms of some general recommendations, and then I'll look at it specifically to or specific to healthcare providers. And so, as for some general recommendations, we need to address the social determinants of health that were mentioned in those theoretical models. We need to address them through policy. So, this can look like bridging the income gap, some paid time leave, access to better environment, and this includes education, housing, transportation, policy reform for extended Medicaid coverage and paid family leave. And I will acknowledge that this is underway. So, for example, here in Illinois is one of the only 5 states. I think some others were on the West and East Coast to require screenings for maternal health conditions. And so Governor JB signed a Illinois Birth Equity Initiative into law that requires insurers that provide state regulated healthcare plans to cover pregnancy and postpartum services for covered individuals. And this includes services like midwife services, doula, lactation consultants for up to 12 months after the end of pregnancy. And so I mentioned that because that aligns with supporting Medicaid expansion that extends beyond the typical couple of months, 60 days or what have you. And I will mention later in the presentation about the White House blueprint that was in place addressing the maternal and health crisis. And we also have the advancing women's health and research innovation that was still and is still a part of the federal legislation, and so many more good examples of what we're doing and some synergy around some efforts. Another general recommendation, we need to address affordability and accessibility to healthcare. And so, and it's blocked off a little bit here. Let me go back. So we really need to address and have overall better healthcare access and quality prenatal care, prenatal and postpartum healthcare facilities in underserved communities, home visiting programs, group prenatal care, addressing support again, more comprehensive and integrative support services, including community health workers, doulas, midwives, etc. Um, and one other thing, it's important to have kind of the maternal care providers collaborating with community-based organizations to kind of just integrate support services within the community. And so this is just a couple of general recommendations, but overall, we do need to address kind of the affordability and accessibility to healthcare. Expanding on access a little bit more. We need to really, and we're doing this, tap into a little bit more of uh, telehealth options for prenatal and postpartum visits, especially in rural and or underserved areas, coordinated care models for additional support advocacy, and extending kind of the postpartum care after birth. Expansion of state Medicaid programs, talked a little bit about this, outreach and education to enrollees. And there are some exemplary programs to benchmark. Ohio's Comprehensive Maternal Care Program, they really talk about the importance of engagement with patients and their families around how to access care, how communication methods affect patient outcomes. Again, Illinois Birth Equity Initiatives, increasing awareness of postpartum warning signs and improving kind of that provider patient communication. Again, this connects back to that theoretical orientation that was displayed before. Now, getting into some recommendations and strategies and tips for healthcare providers, and what this could look like. So it's important to have mandated trainings, continuing education to address racial and implicit biases and general education around this area. Another point, medical education training reform, really using that as a shared decision making tool on training around racism and implicit bias. And the trainings need to be regular. They need to be ongoing, the CEUs. As for patient education and that shared decision making, this could look like providing health education to patients about the warning signs during pregnancy and postpartum. Things as simple as headaches, swelling, or excessive bleeding. The shared decision making could be around topics such as burden plans or pain management interventions. So we have some room there to kind of increase what we can do to kind of address this maternal and child health issue. Diverse workforce. Advocate for more diverse healthcare teams. I'm harping on the idea of the importance of multidisciplinary care teams to kind of support maternal and child health care outcomes, but it's important. We need different and interdisciplinary professions all working to address and solve this issue. So again, diverse workforce, multidisciplinary care teams, midwives, doulas, more awareness about Black maternal and infant mortality. Why are these things the way that they are? More education, CEUs, culturally sensitive medical interventions. This is one of, I would say, my most important slides because I think it's so important to build trust between the patient and the clients. And so listening to patients and taking the pain conversation seriously. I can give some personal anecdotes as well, but it's important to listen to that patient. And this is that kind of shared decision making and really considering um, the patient as a key stakeholder in their health and their health outcomes. Re-envisioning prenatal care visits, and this is what I was talking about, driven by the mother, assistance in helping Black women and helping women in general advocate for their own well-being. acknowledging a history of racism, discrimination in healthcare, partnering with community organizations. A lot of the community-based organizations, they are rooted in the community. That's a way to really build trust, and have a better reach to the high risk patients. It's so important to partner with those community organizations that's in the community, and interdisciplinary teams. And so accountability is important. We need evidence-based clinical protocols, quality care measures, better follow-up with high-risk patients, and monitoring. When we're talking about the discharge, it's not just, you had a baby, you're out of the hospital 2 3 days later. We'll follow up with you a couple of times, and then you're done, you're on your own. We need better follow up, specifically for those high risk patients, and monitoring. Some standard protocols will be useful when it comes to managing those obstetric emergencies. So hemorrhage, hypertension, sepsis. It's important to kind of have some standard protocols around um, those emergencies. Early warning signs and systems for high risk patients. This is something that we have to do a better job. Also in the education realm of things around those early warning signs, and then postpartum follow up. This is a whole nother presentation, but screening for mental health and preeclampsia, the standard discharge plans. We have to be accountable and have some evidence-based clinical protocols in place. Data collection is very important. Observational studies and quality improvement. Data is important. Making data-driven decisions. Review committees. Assessment evaluation is also key. So looking at those patient-reported outcomes, kind of really tracking those experiences, satisfaction with care, not just treating them just like it's just something to do, another thing to do, assess our patients, but really looking at that and seeing what were those experiences, how satisfied were the patients, our population, and then providing some educational resources. Some recommendations and strategies and tips for healthcare providers. Again, I want to connect this back to addressing the social determinants of health, and those theoretical models that were presented earlier. But in terms of looking at this and looking at the food environment, economic stability, it's important to extend the screening, looking for some of those social determinants of health, looking at screening for food insecurity, screening for housing instability, and just general barriers or stressors that can impact, again, those outcomes. Transportation barriers, intimate partner violence, connecting patients with community resources or community-based organizations to that offer community services. Education. Really being able to convey the importance of realizing those warning signs. That joint shared decision around birthing plans and pain management, and also literacy. Just having available interpretive services for those who may need that service. And so I talked about this earlier, and I wanted to kind of circle back here because there was a big movement made up under the last administration around um, what we need to do to address this crisis. And I wanted to highlight this again because we really need to keep this momentum going. Some examples of recommendations and strategies that were highlighted in this blueprint were like goal one, we talked about this, but increasing access to coverage coverage of comprehensive, high quality maternal health services, and this includes a lot of those behavioral health services. The problem explains how there are gaps in insurance coverage before and after pregnancy. There are maternity care deserts and individuals that do not get timely prenatal delivery and postpartum care, including that behavior care. So the action from the White House at the time under the last administration was to kind of eliminate that coverage gaps by encouraging states to extend the Medicaid coverage from 60 days to a full 12 months postpartum, improve the obstetric readiness of hospitals without obstetric units so they can have adequate capabilities to kind of safely perform deliveries, ensuring women return to primary care after the end of their pregnancies, which is a critical step to ensuring patients remain healthy long term after their pregnancy. Continuing to invest in maternal behavioral health by launching a 24/7 national support hotline for pregnant individuals and new mothers facing mental health challenges and improving kind of provider education. So overall, just more investment in telehealth and remote monitoring, providing resources for the population that they maybe can use at home afterwards, providing blood pressure cuffs or glucose monitors, with education for women at risk of preeclampsia, of gestational diabetes. And so these are just some examples, and it's just important to keep this blueprint at the forefront, just so we know how we can keep the movement going to address these um, issues that we see around maternal and child health. So just in terms of a few concluding thoughts, and I want to go back to my original agenda. And as mentioned in the literature review, we know the significance of the issue. We see what's happening. It's certainly a crisis. It's certainly a problem. Um, in general, the maternal and child health is a crisis, but Black women are also faring worse with pregnancy outcomes. And as for the factors contributing to this, there are many. My word of the day is multifaceted. There are a host of different factors, and this is the reason why it is important. It's difficult to pinpoint causality, and there are interacting factors at play when we look at the social determinants of health. So, what do we need? We need systemic change. And a lot of this can occur through some policies. Cultural competence in care, it's important. It isn't a one shoe fits all. Healthcare providers, they they can be the difference makers. We can use more prenatal and postpartum healthcare facilities in underserved communities. We can use more integrative care with midwives and doulas and community health workers. We can use more home visiting programs and group prenatal care, really addressing the support. We can use more education and awareness in the communities, really leveraging the relationship with community-based organizations. And lastly, I want to go back to what I said was um, one of my most important slides, just because it resonates with me on so many different levels. It's important to build the trust between patients and clients, and that's connected to that theoretical orientation as well. We need more listening to the patients. We need more um, kind of that shared decision making, taking the pain conversation seriously. We need to listen about after in the postpartum. What are the problems? What's going on? We need to get women back under care immediately if things are going on. We need to re-envision prenatal care visits. Again, really honing in on the fact that the mother, the patient, is a key stakeholder in the overall health and well-being of the individual. We need assistance in helping Black women advocate as well for their own well-being. And lastly, again, we need more partnering with community organizations to build that trust and have a better reach to high risk patients. And so I want to stop right there. We have about 10 minutes for some questions. I want to drop my contact information here, as well as I have a link to the references that I use. And I will stop right there and take some questions.
Thank you so much, Dr. Clay, for that presentation. We do have quite a few questions. We won't be able to get through them all, but we will have a FAQ and we'll post it to our website, our Facebook, and our YouTube page. So the first question is, how do we navigate this given the current political climate and the views of diversity, equity, and inclusion?
That's a good question. The political climate that we are in now, it is certainly challenging. It's challenging talking about kind of those racial and health disparities that exist specifically for Black women. And I think, this is where I would say we need to have more representation in those interdisciplinary health teams. We need to have more representation that kind of know what's going on and willing to step up and help, giving the pressures that we're seeing with the political climate. We really need to leverage those interdisciplinary teams, those midwives, those doulas, which um, and I'll say it with Black women, Black doulas. We need to kind of leverage those interdisciplinary teams and kind of do what we can, knowing what the pressures that we're up against. It's difficult. It's going to be challenging, and we have to keep going.
Okay, thank you. The next question is, how do we navigate this given the current political climate and their views on, I just answered that. I'm sorry. The next question is, any tips on having these conversations with our board and staff that may be reluctant to acknowledge and or address this information?
Yeah, I think I think what is well received in the healthcare sector is um, driving your agenda through data. And so I think we'll always be met with some reluctancy. I think the only thing that we can do is present it and see what the outcome is. Um, it's always going to be some level of resistance, but I would suggest starting with the data and really being intentional about what the data is showing and what's needed. And so it's important, and I said this with the last question around some equity and inclusion, but it's important to have representation on those boards as well, just so we can continually highlight what is going on, what the data is showing, what the research is showing, and then making some moves and kind of leveraging that data to again um, push the narrative, push the agenda.
Okay, thank you for that, Dr. Clay. The next question is, what role do midwives, doulas, and community workers play in improving maternal and child health outcomes?
This is a great question. They really offer kind of that support, kind of that advocacy, kind of that listening ear that I was talking about in the presentation. And so I can extend this to all of the different healthcare workers. We need to leverage kind of interprofessional education and teams, and know that each role, um, each individual in that role, they bring a different expertise. And so when I'm talking about the midwives and the doulas, I think that they bring a different level of support and advocacy that may bridge kind of that um, relationship between other healthcare providers.
Okay, thank you. The next question is, how can providers improve patient-centered care for expecting mothers, especially those from marginalized communities?
I like that question as well. I think it goes back to the presentation and um, saying that the issue is multifaceted. It's certain things that the healthcare provider can do, but there are also things that institutionally can be done as well. And so I think um, to leverage a little bit more and go in a little bit more on that question, I think it's important that we look at policy. Um, and I think this goes along the line with some previous questions as well. But it's important to kind of look at policy and things that we can do to change the dynamics and the trends as it relates to policy.
Okay, thank you. The next question is, how can healthcare institutions better support providers in delivering equitable maternal care?
And so I was just touching a little bit on this question previously, but I would say that it's all in kind of the policies. We need to address a lot of those social determinants of health through policies. And I'll go back quickly to that slide. Um, and these are some things that extend beyond just healthcare institutions, but bridging kind of that gap, that income gap, paid time leave. This again, it extends beyond the healthcare institution, but within the healthcare institution, it will be about screening for these things. So access to better environments, education, housing, transportation, and really trying to look at those stressors that individuals may be experiencing and seeing how we can eliminate those stressors that again link to a lot of those health outcomes.
Okay, thank you. And the last question, do you provide implicit bias training for organizations?
We can talk a little bit more about that question offline. Whoever had that question, I'll put my contact information up there again. I'll be happy to talk to you about the answer to that question offline. But I can certainly provide some insights around those trainings for organizations.
All right, once again, thank you so much, Dr. Clay. And thank you everyone for joining us in this